Yes. So all the online attendees will be muted throughout the presentations. If you have questions for the participants, please put them in the chat and we will read them at the end of each presentation.
In this session, you'll be hearing presentations from the Allied Health Department. Each group will have 12 minutes to present and 5 minutes to answer questions. I'll inform presenters and Michelle will inform virtual presenters when there are 2 minutes left. Judges, we will also be providing you with participant ID numbers that will go at the top of your judging form. So let's begin. First, we have Casey Gilry presenting her work, Lewis Blood Group System. Judges, please note the participant ID number is 3001. Yeah. You can hit share. And then, yes, perfect. The little bar all the way to the right. Yeah, perfect.
Good afternoon. My name is Casey Gilry, and I'm a part of the Medical Laboratory Science program here at LSUA. And today I will be speaking with you about my project, which was the Lewis Blood Group System. So the subject matter of this presentation consists of antigen facts, antibody facts, genetics, a brief overview of the biochemistry, the demographics, and the diseases that are associated with the Lewis Blood Group System. The Lewis Blood Group System shares one similarity with the ABO blood group system, and that both require 3 inherited genes for development. What makes the Lewis Blood Group System unique will be discussed throughout this presentation. The Lewis antigens, which are LEA and LEB, are unique when compared to other blood group systems because they are only made by tissue cells and secreted by these tissue cells, which explains why they're only present in plasma and secretions. So in plasma, they're present as glycolipids, and in secretions, they're present as glycoproteins. These antigens are also non-essential to the red blood cell, but the red blood cell will still absorb them. The Lewis antibodies are class IgM, which means they're irrelevant when it comes to typing. The Lewis antibodies do not cause in vivo cell destruction, and the reason for this is whether a person is given LEA or LEB blood, a neutralizing effect will occur. And because these antibodies are class IgM, they'll cause no hemolytic disease of the fetus and newborn because they're too large to cross the placental barrier. The Lewis antibodies are considered cold class antibodies, which means they agglutinate at room temperature. However, for the Lewis system, the optimal temperature is 4 degrees Celsius. However, agglutination can be seen at 37 degrees Celsius, the immediate spin phase, and the AHG phase for the anti-human globulin phase. There are 3 main genes when looking at the Lewis system, and these genes are LE, H, and SE. So the LE or the Lewis gene is in lower activity than the SE or secretor gene, which allows the secretor gene to modify type 1 chains in a greater quantity. Both LE and SE genes act on type 1 chains, which are oligosaccharide chains that attach to either lipid or protein carriers. The H antigen is a critical part of the Lewis system as it allows for LEB to be formed. So without that H antigen, it would form LEA in its place. The Lewis gene is expressed by attaching the L-fucose sugar to the number 4 carbon of the N-acetyl glucosamine, and the H gene attaches the sugar L-fucose to the number 2 carbon of the D-galactose on the type 1 chain. So the first reaction is a beta 1 to 4 linkage, and the second is an alpha 1 to 2 linkage. How these sugars are added is important when looking at the phenotype that is going to be present. So for instance, if the Lewis gene adds first, that means the chain would turn into LEA, and at this point, no further modifications can be made. However, if the secretor gene is added first, the chain turns into H, which then allows the Lewis chain to attach, but it turns into LEB instead. Okay, so this is just a picture of the different chains and how they attach together. Don't get confused by this picture because it says 1 to 3 linkage, but that's just talking about how the type 1 chain itself is made and not how Lewis is added to that chain. Newborns in fetus phenotype, regardless of ethnicity, will be LE A- and B-, and from birth to age 6, the typical phenotype is LE A- and B+, and this is usually when the typing stabilizes. LE A- and B+ is seen in 72% of Caucasians and 55% of African Americans. LEA+ and B- is seen in 23% of Caucasians and 22% of African Americans. A very small percentage of people have the LE A- and B- phenotype, however, with 6% of Caucasians and 22% of African Americans expressing it. There has been several diseases that have been associated with the Lewis blood group system, like H. pylori and the Norwalk virus, which is associated with the LEB antigen. There's also Candida and E. coli that has been seen in greater association with the phenotype LE A- and B-. Of the over 30 different blood group systems, this presentation has focused on the Lewis blood group system. The subject matter of this presentation consisted of antigen facts, antibody facts, genetics, a brief overview of the biochemistry, the demographics, and the diseases that are associated with the Lewis blood group system. I hope from this presentation you have learned a little bit more about the Lewis blood group system. This is just some pictures that I took in the lab. First picture is when we were doing a coagulation test, just some things to show you. And this is my references. Thank you for your attention.
Nice. Do we have any questions for this?
Comment. I was so impressed with the smoothness of your vocabulary with all that stuff that I know nothing about.
Yeah, I'm a little nervous saying it, but I've presented multiple times, so it makes me a little bit more comfortable. But yeah.
Yeah, that was excellent.
Thank you though for that compliment.
I just have a question. You had said that the E. coli was prevalent in the LEA- and B-. I think. How do you know how prevalent it is? Like, does it occur often or is it rare?
I didn't see anything that referenced how often it was. I just know that it is from the research I've seen. So nothing said anything about percentages or anything like that. So I'm not sure. I would have to look that up for you.
Okay. I was just curious.
Right, I understand.
All right. Any questions on Zoom for Casey?
No, Danielle.
All right, thank y'all.
Yeah, thank you.
Yeah, great job. Okay, well, next we're going to have a group presenting for us. It will be Bailey Cooper, Alexis Washington, and Lacey Foreman, and they're going to be presenting osteoporosis in radiology. Judges, please note their participation ID number is 3002. So, ladies, please begin.
How are y'all today? Good. Okay, well, my name's Bailey. This is Lacey, and then we have Alexis on here. I don't see her, but she's on here. Okay, share this, right? Share, and then this. Can y'all see it?
You see your,
We're actually seeing your email.
Okay, stop share, and then share again. Share again. There it is. I got it. Can y'all see it now?
Now we have it. Great. Thank you.
Okay, awesome. Okay, so like I said, our names, then we actually picked osteoporosis for our project in radiology because we deal with bones, obviously, so we wanted to go through this pathology with y'all. First, to go through, you have to understand the origin and where it comes from, which are the bones. The functions of the bones support the body structure, protects the vital organs, creates movement, provides an environment for bone marrow where blood cells are created, and acts as a storage area for calcium. At birth, you actually have 270 soft bones, and then as adults, you have 206. And the largest bone in the body is the femur, which you'll see we did our model on, and it's anatomically correct, and you'll understand in a second. Okay. So how do bones operate? You have the joints, which articulate between two bones in the body held together by tissue. Three types of joints are the synovial, cartilaginous, and fibrous joints. The synovial are freely moving, which is the shoulder and the knee. Cartilaginous is slightly movable, which is the vertebrae. And the fibrous is immovable, which is the skull. Okay.
All right, so what is osteoporosis? So osteoporosis is a condition in which bones become weak and brittle. The body constantly absorbs and replaces bone tissue, but osteoporosis, new bone creation, doesn't keep up with the old bone removal. So the condition often affects women after experiencing menopause, but also may be found in men, but rarely found in children. All right, so we have a few pictures right here just to explain what osteoporosis is and what it looks like. So on this picture right here, it just shows that this is what a normal bone would look like before you were diagnosed with osteoporosis. And then this, as you get older with age, or not even with age, it can just turn into osteoporosis like this. So it just becomes like the opening of the spongy bone just absorbs, I guess, gets larger. And then in these pictures, I guess, as osteoporosis goes further along, it just gets worse.
You can really see how the bone thins out and how the spongy bone really just expands. And you can tell when it expands, it does get thinner, which will make it more brittle and make bones break more easily.
So again, right here, we have a couple pictures. So this is, again, the normal healthy bone, whereas this is the more osteoporosis. It looks more stringy than the normal healthy bone. So osteoporosis is also known as the silent killer. So osteoporosis means porous bone. It is a disorder that leads to thin and weakened bones, making them more prone to fractures. Then there are usually no symptoms until a bone is broken, or it is often called the silent disease. All right, so again, with another picture, this is just a normal bone, and then you see how it's like widened out for the osteoporosis bone. It's also similar to like honeycomb. So this is healthy bone versus osteoporosis. So viewed underneath the microscope, healthy bone looks like honeycomb, like I just said. When osteoporosis occurs, the holes in the spaces in the look like honeycomb, which is much larger than the healthy bone. Now Alexis is going to take over this point. Let's see if she sees it. Can you see it, Alexis?
Yes. Okay, so how to diagnose osteoporosis is through bone densitometry, small dose of ionizing radiation to produce images to measure bone loss, and used to properly diagnose osteoporosis and to stop the risk of osteoporotic fractures. And on the left side is, and osteoporosis often shows no symptoms at all, making regular screenings important. Bone density test is required for official diagnosis. Physician must diagnose underlying cause like aging or hormonal changes. And risk factors include history of smoking or diet deficient in calcium or vitamin D. Did you change it, Bailey?
Yeah. Can you see it?
Okay, so for the exam prep, it's little to no special preparation. Make sure patient is not pregnant or recently had barium or contrast material for a CT scan. No jewelry, of course, and patient must wear loose clothing or be asked to put on a gown. X-rays can only detect bone loss after 25 to 40% of the skeleton has degenerated and should not be used to identify osteoporosis. I'm sorry, it's going slow for me. Okay, so here we have a few pictures. In the top left corner, you see a X-ray exam, and it shows the osteoporotic on the left side and the healthy on the right. And you can kind of see the difference in between the femur necks of it, yeah. On the bottom, underneath it, on the left side, it shows the healthy bone, and on the right, it shows the osteoporosis. The top right corner, it shows like the honeycomb we were talking about. You can see with the normal bone, it looks more like a honeycomb. In the osteoporosis, the spaces are much larger. And the bottom shows hip fractures due to osteoporosis in the femoral head and the fracture in between on the neck. So osteoporosis can be prevented by exercising regularly. These exercises help maintain increased bone mass and density, and different exercises include walking, hiking, dancing, stretches, and yoga.
Okay, so the fun part, our model, we actually took bamboo, sponges, and clay to actually make it. It's actually very anatomically correct. It is the size of my femur, and it's, let me get the other pictures. Okay, so you see the backside, it's kind of cracked now with fractures, we're gonna say. You can see how it has the neck, it has the femur head, all of that. Then you go to the other side, you have the osteoporotic bone, you have the compact bone, which is the outside of the bone. That's the hard white. And then you have the healthy bone, which is down here, that you can tell has the normal texture, honeycombs. Thank you, honeycomb. And then you get up here, which is the osteoporotic part, like I said earlier, and you can see how the holes widen and they don't look very healthy. Then you get down here, this is all inside of a bone is spongy bone, and then it's compact with compact bone. So that's our model. Let's see. Okay, up close, you can see the healthy bone, the honeycomb structure, and then the osteoporotic bone at the very top. Here are our references and where we got all of our information. And then this is a picture of us from our pathology project. We have Alexis down here. She actually had a baby, so she's out for right now, but she is here today, which we are very thankful for. And then that's the end of it.
All right. Thank you all very much. Very informative, scary, icky stuff. Thanks so much. Okay, our next presentation is going to be Benny Lucas, Caitlin Rasmussen, and Carleen Weingart discussing, oh, and they taught me how to say this, Volvulus in radiology. Did I get it right, ladies? Judges, their participant ID number is going to be 3003.
Megan, Michelle, do you want them to have question time?
Shucks, I got so excited and I just went forward. My apologies to the previous group. Yes, question time, please.
They have 5 minutes for questions. Any questions in person?
I'll ask a question. I'll take this off so y'all can hear me. So, to diagnose osteoporosis, y'all were talking about the BMD, the bone mass density or bone densitometry. How is that an effective way to diagnose osteoporosis, and how much radiation dose do you get?
I'm not very sure on the exact number on how much radiation dose. It's not very much. I do know that it's not as much radiation as you would get as a regular X-ray or a CT scan. What was the other question? Oh, it's actually very hard to see it on an X-ray at first. That's why to find osteoporosis, it's actually very accidental. You go in for a break when you're older and you're like, oh my gosh, I'm very brittle now. And it can be because of age, but once you go in and you get an X-ray, and if they can't really see and they can't really tell the issue, you'll go back in for a bone density, and they'll be able to actually see a very closer and more detailed look on your bones, and you can tell, they'll be able to tell the brittle and why it's so thin.
Yeah, because that's what they're looking for when you go for bone density
Mhm.
testing. You look for that certain specific disease.
Thank you.
Any other questions?
I just want to say congratulations to Alexis, and ladies, I'm proud of you for doing your presentation when everybody wasn't in the same spot.
Thank
Thank you.
We've been saying
Thank
we have a rad baby now, so we're very excited for her.
Thank you.
Any more questions?
That's all for us, Michelle.
Okay, I guess we will go ahead and go on to the folks I've already introduced. And again, my apologies, final group. Again, their participation number was 3003. It's going to be Benny Lucas, Caitlin Rasmussen, Carly Weingart, and Volvulus in radiology. Please.
All righty, hey, let me go ahead and share my screen. Okay, can everything be seen by y'all on y'all's end?
Yes, we have it.
Okay, so Carly's gonna go ahead and introduce.
Hey, my name is Carly. I'm here with Caitlin and Benny. So I'm going to start off with our presentation. We have volvulus in radiology, which volvulus is a pathology that can occur in the human body. First, we'll start by talking about the purpose of the gastrointestinal system. So the main functions are to digest and absorb the ingested nutrients and excrete the waste products of digestion. So in the GI system, there are several organs involved, which starts with the mouth, goes to the pharynx, through the esophagus, to the stomach, through the small intestine, then through the large intestine, to the rectum, and then the anus. Okay, so how the GI system works. So each part of the digestive system helps move food and liquid through your body, or it breaks it down into smaller parts. So once the food is broken down small enough, the body can properly absorb and move the nutrients to where it needs to go. So like I said before, it starts with the mouth, and once it makes its way to the stomach, the digestive juices help break down the food to where it then can be moved to the small intestine. While it's in the small intestine, the water and nutrients are absorbed and sent into the bloodstream. From the small intestine, then the products begin to move to the large intestine, where in the large intestine, the water is absorbed and stool is formed and prepared to exit the body. So now we'll talk about the pathology. So what is a volvulus? A volvulus occurs when the organ twists abnormally around itself and its mesentery that supports it and it causes a obstruction. The area above where the twisting occurs continues to function properly, which can cause the backup of food, fluids, or gas. So the organ can become so tightly twisted that the blood flow can be cut off. So volvulus can occur in several different areas. It can occur in the stomach, which is classified as a gastric volvulus. And then you have the small intestine and the large intestine, which is classified as the intestinal volvulus. So in the large intestine, you have the two main spots it can occur, which is the cecum and the sigmoid colon. So to touch on the gastric volvulus, it occurs when your stomach twists on its mesentery. It has to have a minimum of 180-degree rotation and cause a bowel obstruction to be considered a volvulus. So there's two types of gastric volvulus. So the first one is the orangoaxial, which is more common in adults and is responsible for 60% of its presentations. And then you have the one that is more common in pediatric patients, which is the mesenteroaxial.
Alrighty, so I'm gonna be going a little bit into more depth on each kind of the gastric volvulus. So the first one is an orangoaxial, and that is when the stomach rotates along its long axis, and there's a line drawn called the cardiopyloric line, and that's where it flips over. So it mirrors the normal anatomy. The greater and lesser curvatures of the stomach will be reversed. So the pyloric antrum rotates anterior-superiorly, and the fundus rotates posterior-inferiorly. So here's just sort of an illustration. Here is that cardiopyloric line, and you see the arrow that it goes over itself. So here's some images from other patients, like real life. So here is a normal chest x-ray where you can see that the stomach is flipped. And then here it is when the stomach is full of barium. It's a little bit better of a picture to be able to see the rotation. So with the mesenteroaxial volvulus, the rotation is around the short axis from the lesser to greater curvature where the stomach appears upside down. So the pyloric antrum is displaced above the gastroesophageal junction. The antrum and pylorus is superior to the fundus and proximal body. So here again, here's that line that's drawn and you see it flips over itself. And then here it is just on a normal chest x-ray. And then once again, when the stomach is full of barium. So with intestinal volvuluses, a volvulus can occur in both the small and large intestine, like we said. Small intestinal volvuluses primarily occur in infants and children. So they're normally born with it. So we didn't go into much detail on it as a pathology. We mainly focused on the large intestine. So a large intestine volvulus accounts for about 5% of all large bowel obstructions and is more common in the elderly. There's two main types, a cecal and a sigmoid. The cecal accounts for about 10% of all intestinal volvuluses and generally occur in somewhat younger patients in the 30 to 60 year range. The sigmoid volvulus accounts for about 60% of intestinal volvuluses, and then they involve the sigmoid colon. So the cecal volvulus is a twisting of the cecum and ascending colon around its mesentery. The few factors that are important for the development is a failure of peritoneal fixation, which allows proximal colon to be free and mobile. So that's where your colon is supposed to be attached inside of your body, and somewhere along the line that connection is malformed or broke, whatever happened to it. It's not allowed to be fixed to the inside of your body, so it just moves around. So the restriction of the bowel at a fixed point within the abdomen, which acts as a fulcrum for rotation. So with the sigmoid volvulus, it's the most likely cause of a volvulus is a twisting of the sigmoid colon. The anatomic problems that increase a person's risk for developing a sigmoid volvulus include an elongated and movable sigmoid colon that is not attached to the left wall of the abdomen, a narrow mesentery connection at the base of the sigmoid colon, malrotation that is present at infancy, if you're a male, if you're older than age 60, and then typically people living in a nursing or psychiatric facility. So as you can see on some of the x-rays over here, when you take an x-ray of a patient with a sigmoid volvulus, you instantly see it. because it has this large sort of bean shape. And it's very striking when you take an image and that's the first thing that you see. Alrighty, so Benny is going to go into some of the diagnostic imaging.
Diagnostic imaging for volvulus. Modalities for diagnostic evaluation of a volvulus is radiograph, fluoroscopy, and computed tomograph, which is CT. In diagnostic, what we use as protection is something called ALORA, which is as low as reasonable achievable. How can you reduce external radiation exposure? That is time, distance, and shielding. Limiting the time of radiation exposure will reduce your radiation dose. Reducing radiation dose, you will increase KV, and decreasing your mass will reduce exposures. Distance, increasing the distance between you and the radiation source, you will reduce exposure by the square of distance. Doubling the distance between your body and the radiation source will divide radiation exposure by a factor of 4. Shielding, lead or lead equivalent shielding for X-rays and gamma rays is an effective way to reduce radiation exposure. Volvulus symptoms. Symptoms may start with cramping and then pain becomes worse until it becomes unbearable. Diagnosis of volvulus is a high suspicion based on presenting symptoms, which include abdominal distension, abdominal tenderness, vomiting, blood and stool, and constipation. Sigmoid volvulus. Abdominal radiographs will show a large dilated loop of the colon, often with a few gas fluid levels, which will be coffee bean sign, absent in rectal gases. Cecal volvulus, an abdominal X-ray will reveal a dramatic dilation of bowel extending from the right lower quadrant, moving upward to the left upper quadrant of the abdomen. An abdominal pelvic CT scan is diagnostic for cecal volvulus in approximately 90% of the patients. Gastric volvulus in chest X-ray often reveals retrocardiac and air-filled gastric shadow, while abdominal radiographs reveal a distended fluid-filled stomach. Computed tomograph CT of abdomen and pelvis with IV and PO contrast with multiplanar reconstruction is the first line for a diagnosed volvulus. It increases the sensitivity of the volvulus detection and is best demonstrated when the imaging axis is perpendicular to the axis of rotation. For large bowel volvulus, imaging may show bowel dilation and other signs of diagnostic for cecal or sigmoid volvulus. Precaution of imaging procedures. Radiographs will provide information on degree of obstruction or complications from volvulus, which will often affect clinical management. CT exposes patients to ionizing radiation. If a complete or high-grade obstruction is suspected secondary to volvulus, then oral contrast should not be given. IV contrast should not be given in patients in renal failure who are not on an adequate and CT appropriate dialysis regime. And that is it from our presentation.
Alrighty, so we've just included some of our references. And then with the previous group, we have a presentation poster board, if you want to call it. And on this board, we demonstrated the 2 most common types of volvuluses. So in the stomach is the orangoaxial, and then in the large intestine is the sigmoid volvulus. So we sort of had to get creative to find a way how to make intestines and how to make them flip. And so this just demonstrates how that would look. Alrighty, and then that is the end of our presentation.
That was fantastic. Thank you, group. Does anyone have any questions?
What is the most severe for your patient? Which volvulus is the most severe?
I'm sorry, I can't really hear what she's saying.
She's asked, what is the most severe volvulus for your patient?
When you're reading sort of about the types, they all have dependent on the patient. So with the sigmoid volvulus, you can easily say, if anywhere that cuts off blood supply in your intestines or in your stomach, that's going to be a major problem. So it's sort of hard to say which one is the most, like that's the worst one, because it just varies on degree of how bad it is versus the patient themselves. But like going off of these images, you would believe that the sigmoid volvulus, like it's pretty intense. Like your bowel becomes obstructed and it just keeps growing inside of your abdomen.
We have a Zoom question. How is this repaired if a patient has this?
So it's sort of a weird, that's sort of like a weird process. Normally they treat the obstruction. So one way that they may diagnose this is through something called a barium enema. Sometimes that barium enema, just the act of the cleaning that goes out for that exam, can untwist that loop. Or when you pump a person full of barium, sometimes that will sort of unkink the loop itself too. But as far as, do you have anything to add on as far as like actually going in to remove it? It would require surgery if the testing itself doesn't unkink it on its own.
Are there any in-room questions?
And then Maribel James asked, can you please explain why men and people over 60 are in nursing home residents or psychiatric facilities are at high risk?
So as far as being male, I'm not sure why that's like more of a statistic that it's males. But as far as the people in nursing home facilities or in psychiatric facilities, they're not up moving around as much as a normal person would be moving. So if you're laying in bed all day and you're eating, and like that's more likely to cause an obstruction or a twisting, like the gravity's not there to take into effect to get your intestines moving like they need to be moving. So normally those people that are more sedentary, like they're not able to get up and move around. It's just, they don't know why it happens, but they're more at risk for developing them.
Any other questions from the in-person audience? All right, that's it for us. Thank you, group. That is amazing nightmare fuel for me as a
For me, it's the osteoporosis.
teamwork.
It's all the key. Yes, thank you so much, everyone.